Hello, everybody. Good afternoon and welcome to this launch program, our first ever online CME under the conference Premium CMEs platform. I'm very happy to be the person who does the first ever online CME on infertility management in this series and to debate this difficult topic, which is affecting 10 to 15% of the entire world's population. We have a galaxy of eminent stalwarts from all across the country who are here to debate and deliberate on various different aspects of infertility management. I'd like to thank Conference and the entire backend team, which has been working very hard behind the scenes to put this launch program together. And I wish all of them all the very best for this event. We have two eminent speakers in the shape of Professor Pratap Kumar and Dr. Ritu Khanna, who will be speaking to us shortly. And after that, we have a panel discussion on how we can optimize and enhance our ART results, irrespective of what kind of clinical situation we find ourselves in. So, without further ado, I would like to take the opportunity to welcome everybody who is logged in and tuned into this event and look forward to a couple of hours of raw, solid learning, which is based on the most current guidelines which are available to us. I'd like to introduce the chairpersons for the first session. Can we have the series on screen, please? First and foremost, I'd like to introduce Dr. Ramani Devi. Madam is a past Vice President of FOXI. She is known to be a leading light in the field of endometriosis. She has won accolades for her research in this particular field, and she is well known to all of us as a very eminent and senior teacher from South India. I'd also like to take the opportunity to welcome our second chairperson, Dr. Mala Srivastava. She is a governing council member of ICOG. She's a past president of the AOGD, that's the Association of OBGYNs of Delhi. She is also vice president of ISOPAB, and she's somebody who's known to us, who has made great strides in the field of endosurgery and robotic surgery. Several accolades to both of our chairpersons credit. For want of time, I will not go into individual awards, but both of these are legendary figures from different parts of India as far as academics is concerned. And I would hand over the session to them to carry the proceedings forward. Our first speaker of the day is going to be Professor Pratap Kumar, and Dr. Mala Srivastava has requested that she be allowed to chair his session and to introduce him since she is joining us from the OT. As you can see, she is in OT guard. Thank you very much for your commitment and honoring the commitment, ma'am. Over to you.
Good evening, everyone. It's always a pleasure to be connected with Dr. Pratik Tambe. He's such an academician, and it's a pleasure also to share the same platform as Madam Dr. Ramani Devi, who is such a great legend. It's my pleasure to introduce our speaker of the day, Dr. Pratap sir. He's a very senior person, gynecologist. May I have sir CV, sir? He's a senior gynecologist, a teacher from Manipal Hospital, and we all know as a dedicated IVF specialist. Yes, we have his CV with us.
Mala, you are not audible. I think you are muted yourself.
I think she's actually.
Yeah.
So I was just looking for the CV of sir.
Okay.
It's there on
sir.
screen.
We all know he's a very senior person very senior teacher from South Manipal hospitals, and we all know as a great academician, IVF specialist, very dedicated teacher. He's very interested in all his academic activities that we know, and we all are very eager to listen from him, his scientific deliberation. I would have loved to read his CV, but
Muted.
Backend team, I think we should go ahead.
Anyway, what Dr. Mala has left over I should say that Dr. Pratap is a very, very lovable teacher for many of his students, including my daughter who was trained under him at Manipal. And he has actually brought Manipal to to the level of extreme levels. And most of his students are very well doing everywhere, all over the world. And he has received so many awards, Fertivision Leading Light Award, and then Durusha Award by Izar, and Foxy, Dr. Kutti's Lifetime Award, and Dr. TK Tank Reproductive Healthcare Promotion Top V. And to his credit, he has got more than 300 publications and more than 1,000 presentations. I should say no conference, either nationally or at the international level. It will not be without the presence of Dr. Pratap. And he has authored so many books and contributed several chapters. With this, I'm really honored to chair his talk today.
Second team, can I request you to please go ahead?
Hello, everybody. My topic for today is microbiomes and its impact on assisted reproductive technology. I bring greetings from Manipal University, Karnataka state. We all know microbiome seems to be the new block in town, and fertility is an issue along with the same. Manipal University, that's our university building with 4 floors of library for students and 4 floors of administrative wing. We are in the west of Karnataka state. Human Genome Project from 1990 to 2003 gave a lot of opening for our new chapters. Human Microbiome Project became very, very popular. The first phase was 2007 to 14. The second phase was 2014 to 2019. And beyond that, many more things developed. By looking at the human body microbiome, the human genome is only 23,000 genes. And look at the red big circle there. Human microbiome is huge number, much beyond our own human body cells. And that shows that we have a smaller number than the microbiome. That means microbiome is overpowering us in many ways. To look at these various kind of creatures, I should say, the fruit fly, roundworm, mouse, and the rice genes, that itself has its own microbiome. But the human genome is estimated to contain around 20,000 to 25,000 protein coding genes. If you look at the vaginal lactobacillus species, there are many: L. crispatus, Gasseri, Jenseni, and Inus. We don't need to know all these, but we know that the lactobacillus in the vagina definitely protects the vagina. And if you look at these community state types, CSTs for the vaginal microbiome, the dominant bacteria and the protective or disruptive. Type 1 is Lactobacillus crispatus, which is typically protective. Type 2, Gasseri, is also protective. But if we look at the last type 4 and 5, they are basically the 4. If there's a diverse bacteria, no Lactobacillus dominance, they are typically disruptive. And Lactobacillus jenseni is typically protective. So vaginal microbiome, human vaginal microbiome is characterized by a lot of diverse microbiomes, as we discussed just now. But look at that, you have microbiome composition in different regions. They are different totally. Vagina is different. Skin, gut, oral, respiratory are completely different. Hence, the vaginal microbiota through lifespan is from the birth, pre-menarche, menarche, reproductive years, and menopause. Basically, lactobacillus increases in the vagina and goes down either before menarche and maybe after menopause itself. So we now know the reproductive age and the outcome is very, very important to know. The gut microbiota affects host physiology in many ways by playing roles in metabolic protective function, immune regulation, host defense, structural functions, and histological functions as well. If you look at the puberty to pregnancy, there will be increasing estrogen, there will be maturation and increased glycogen deposition in the vaginal epithelium, and the mucosa basically has mucin, and you'll find all these glycogen to maltose, etc., become lactic acid and then decrease the pH. So we all know a decreased pH is the vagina is usually protective. But when you look at the other kind of problem, vaginal bacteria increases and the pH changes and they get into all kinds of microbiotic activation. The vaginal defense maintains pH. Lactobacillus maintains pH between 3.8 to 4.4. It produces H2O2, lactic acid, and bacteriocins. Hence, they are a protective. Bacterial vaginosis is a condition caused by overgrowth of bacteria normally found in the vagina. And effect of stress seems to be one of the problems in the reproductive health. And you'll find the sympathetic nerve terminals increases norepinephrine, vaginal epithelium is altered, decreases antimicrobial proteins, and there'll be dysbiosis. Dysregulated immune response and pro-inflammatory cytokines. If you also look at the right side of the slide, the stress can increase ACTH, cortisol increase, and they will hamper the maturation and glycogen accumulation, and of course lactobacillus goes down, and when we know the lactic acid goes down, H2O2 goes down, there's overgrowth of anaerobes, bacterial and viral STIs. So triggers basically are stress, toxins, pathogens, food particles, drugs, and infection. If you look at this leaky gut progression, the intestinal mucosal cells, the normal tight junction are seen in the blue there. Entry of toxins, they have a kind of disruption of the epithelial cells and they become very leaky and inflamed. The entry of toxins, pathogens, undigested food particles into bloodstream results in autoimmune response or food allergies, and autoimmune disease will cause poor health. The functions of a healthy gut biome, everybody knows, digestion seems to be the main thing. Immune system support is also associated. Production of vitamin B12, thiamine, folate, etc. Absorption of micronutrients, regulation of metabolism, brain-gut axis communication has been expanded. Maintenance of the intestinal barrier is very well known, and protection against harmful bacteria. So if you look at the complications, people have the reproductive health, gynecological pelvic inflammatory disease, acquired STDs, HIV, chlamydia, etc., morbidity due to vaginal discharge malorder, post-hysterectomy vaginal cuff infection, and of course infertility. Obstetrics, spontaneous abortions, preterm deliveries, premature rupture of membrane, puerperal sepsis, post-abortal endometritis, chronic chorioamnionitis, and neonatal infection. That means all these problems will change the gut flora. So the microbiome plays a critical role in human health and disease, including metabolic disorders, autoimmune diseases, and infections. If you look at these microbial dysbiosis, they are the cause of diabetes, obesity, autism, rheumatic disease, irritable bowel disease, aging, Alzheimer's, cancer, cardiovascular, etc., etc. So in a reproductive health, you realize the dysbiosis mainly is basically it is found in, everybody knows, in cancer, especially endometrial cancer. Polycystic ovary seems to be one new addition which is connected to the gut microbiome. Endometriosis, a chronic inflammatory state, also may be connected to the gut microbiome. In pregnancy, intrauterine growth restriction, and of course later in life, also cervical cancer. And we all know the gut microbiome and the follicular microbiome, endometrial microbiome, cervical microbiome, vaginal microbiome are completely different. So overall, our body, which I told at the beginning, microbiomic genes are genomic stability and instability can cause a lot of chronic diseases. So if we look at this healthy microbiome, especially the ovaries, the body, the liver, and the gut, they all mostly have, you'll realize the most estrogen are exiting out of the body generally, but some estrogen goes back into the body. In an unhealthy microbiome, the ovaries, body, liver, etc., some estrogen, only some will exit and most of it will go back into the body because of the gut leak mechanism which I've been talking about a little while ago. Hence, gut microbiota composition changes and dysbiosis will cause diversity, and gut permeability will cause endotoxemia, promotes absorption of energy, bioconversion of bile acids, amino acid synthesis and activation of the immune system as well, along with pro-inflammation. Hence, all this will cause insulin resistance, hyperinsulinemia, hyperandrogenism, and ultimately PCOS is one of the problems of these kind of gut diversity. So maternal fetal gut microbiota axis, basically, if you look at the gut, colonization of fetal tissues by maternal intestinal microflora, usually in pregnancy, transplacental transport of microbiota derived from metabolites, and transplacental transport of microbiota derived microbial compounds. Basically, what we know is that physiological gestational gut microbiota in composition and function, prenatal impact of maternal gut microbiome and the developing fetus, maintenance of healthy fetal growth and development are all interconnected. Now, what are these biofilms? Biofilms are communities of microorganisms that attach to each other and to surfaces, for example, by bacterial adherence. Biofilms consist of both the cells and the extracellular matrix produced by the cells. A vast number of pathogens in our body are communities called as biofilms. Bacteria form an extracellular matrix around the colony that protects them from antibiotic. That's why sometimes antibiotic doesn't even enter the system what we really want to do, because there are biofilms along with the same problem. So bacterial related biofilm related infection are basically when simple things are bacterial vaginosis. Biofilm comprises mainly Gardnerella, etc., what we all know, and a lower concentration of lactobacilli. Neither the immune system nor antibiotics eradicate all of them within these biofilms. Biofilm-related infections may be persistent, and women with bacterial vaginosis tend to have sometimes even recurrent problems in pregnancy, as told by Garcia Velasco long back, 7 years back. At times, these biofilms may inhibit immune detection and reduce the effectiveness of antimicrobial treatment. These three-dimensional structures spread across the surface of the tissues where they are basically located. Intricate connections between microbiota and endometriosis have been published by Jack Stones, because in 2021, 3 years back, he very clearly said imbalance in the gut and reproductive tract microbiota composition, known as dysbiosis, disrupt normal immune function, leading to the elevation of pro-inflammatory cytokines, comprises of several immune problems, and dysregulation causes endometriosis. Autoimmune disease is on the rise. The effect of infections on susceptibility to autoimmune allergic diseases are also connected to gut dysbiosis. Hence, microbiome and reproduction. When we say microbiota, it means all microorganisms in the body. Microbiome means the genes of the microorganisms. What makes the microbiota? It is basically right from newborn till 3 years. I think the children have the lactation, which protects them from several other things, and they have a good gut. If they're not well fed by the breast lactation itself, the child has a diversity in the microbiota, and he gets into all kinds of problems in the later life, he or she. So in pregnancy, dysbiosis seems to be a problem of even preterm labor. Hence, better always to give a probiotics even in pregnancy when you suspect preterm labor, because that will also cause reduction of the same. When you look at the fertility issue, the seminal microbiome has been studied, and they have found chronic prostatitis, epididymoclitis, etc. will cause infection and reduction of the microbiome itself. How can microbiota affect the immune system? We are all very familiar with the TREG cells and the Th17, and we know that because of short chain fatty acids and surface lipopolysaccharides, all the changes occur in the immune system because of the microbiota as well. If there's a good microbiota, I think they have a better immune system. So hopes for microbiome profiling. Why? It characterizes the microbiome profiles, understand the interplay between hormones, immune system, and the microbiota. Who identifies the patient with immunological problems and what to do, allocate to randomized controlled trials with targeted treatment. Dental department also help us in reducing the infection, periodontitis. All these will cause problems in the mouth, etc. They have definitely adverse on pregnancy outcome and also reproductive health. So nurturing the future, we now know the vital role of modulating the infant microbiome starts from pregnancy, delivery, infancy, and even the toddler. The microbiome can be manipulated to improve human health, such as through fecal microbiota, transplantation, and probiotics. There's lots of talk about it, but in these few minutes, I won't be able to talk about all those fecal microbiota transplantation which people are developing, and of course, probiotic everybody knows. The exact etiology of PCOS still remains unclear. In 2012, long back, it was suggested that gut microbiota may play a role in the PCOS development. Gut microbiota composition changes in women with PCOS, and the changes are associated with metabolic and clinical parameters, though mechanism is not yet fully understood. If you look at the gut microorganisms and PCOS, increased permeability of the gut and release of lipopolysaccharides. I told you a little while about leaky gut. Release of lipopolysaccharides. There will be fat insulin pathway alteration and some TLR pathway. Activation of the bile acid receptors because of abnormal expression, and of course, several of these changes. Activation of immune system, inflammation, obesity, and result in these kind of change will change the mitochondrial metabolism. After the function of the epithelial barrier interferes with insulin receptor action and result in insulin resistance. And we all know hyperandrogenemia and hyperinsulinemia are all connected to these activation of bile receptors, fat insulin pathway, etc. And of course, changing of the mitochondrial metabolism, which is once again connected to the gut metabolism and the pathogenesis of PCO syndrome. Endotoxemia, which I was talking about a couple of seconds back, intestinal dysbiosis and PCOS, vitamin D deficiency is found both in PCOS and diabetes, which impair the intestinal innate immunity, leading to bacterial translocation and endotoxemia. Gut dysbiosis, increase in serum lipopolysaccharide, which I mentioned just now. The concentration which acts on endotoxin destroys the intestinal barrier, increases intestinal permeability, and lead to the change in the mucosal immune system. Endotoxemia promote insulin resistance, chronic inflammation, lipid storage, and other metabolic disorders throughout upregulation of pro-inflammatory signaling, which is involved in the development of PCOS and as well diabetes. Gut microbiota and insulin resistance have been closely associated, and abundance of Pro-Vitella decrease, bacteroids increases, and insulin resistance have been studied. Gut microbiota affect bile acid metabolism, leading to insulin resistance. Bacteroids patients increase significantly, which may be caused by reduction of interleukin 22, insulin resistance, and finally PCOS by affecting the level of bile acid synthesis. Androgen-induced gut dysbiosis disrupts glucolipid metabolism and endocrinal functions in PCOS, published by Quixin Han in 2021 in Microbiome. What is put in the red? PCOS patients frequently exhibit dysbiosis. We have been discussing that. And what is in the blue? In this study, gut dysbiosis was reproduced in DHEA-induced PCOS. Antibiotic cocktail was used to eliminate gut microbiome during the DHEA treatment. However, depletion of the same did not prevent the occurrence of PCOS, but transplanted to pseudo-germ-free recipients triggered disturbances in hepatic metabolism and reproductive hormone imbalance. The clinical features of PCOS may be correlated with the relative abundance of gut microbiomes and the level of fecal metabolites. And of course, all these kind of, basically these are rat experiments, but I think they're giving us clues. These findings indicate that androgen-induced gut microbiota dysbiosis may aggravate metabolic and endocrine function of PCOS. And we always say it's a new player in town. And interestingly, in 2017, 7 years back, Immaculada presented this data and said detection of bacteria with molecular techniques has enabled the study of low biomass microbiomes in tissues and organs, such as endometrium, which is supposed to be sterile. An abnormal endometrial microbiota has been associated with implantation failure, pregnancy loss, and gynecological and other obstetrical conditions. And as always, no consensus has been reached. Now we look at the ART. Vaginal microbiome as it pertains to ART has been analyzed with culture-based approaches. It has been shown that certain bacteria such as Enterobacteriaceae and Staphylococcus found at the time of embryo transfer on the transfer catheters were associated with poor outcome. Hyman et al. Have published it again few years back. Ovulation stimulation and microbiomes. Vaginal microbial biomes have been shown to change during the normal menstrual cycle and varied estrogen levels in the physiological range. It is thus reasonable to assume that controlled ovarian hyperstimulation required to achieve success in IVF would also impact vaginal microbiome. This may represent yet another argument for cryopreservation of embryos and subsequent frozen embryo transfer in a more physiological state, as quoted by Hyman et al. Again long back. Potential influence of microbiome on fertility and assisted reproductive technology. Colonizing the transfer catheter tip with Lactobacillus crispatus at the time of embryo transfer may increase the rates of implantation and birth rate while decreasing the rate of infection. In addition, there is some evidence that the progesterone-resistant endometrium might increase the risk of abnormal vaginal microbiome. Potential influence of microbiome on ART and infertility. It is possible that it is a resistance of the endometrium to progesterone rather than a reduced concentration of progesterone that may contribute to infertility on the basis of the role of inflammation in the induction of progesterone-resistant endometrium. They hypothesize that failure of implantation might be explained perhaps in part by alteration in the uterine microbiome and, of course, inflammation. This putative role of undetected endometrial colonization and progesterone resistance required further evaluation. Ovarian stimulation, the circulating hormones impact greatly upon the microbiome, susceptibility of the woman to infection. Using some 160S RNA deep sequencing in IVF, they found out the shift in vaginal microbiome in some but not all. All these women, basically novel bacterial strains found in 33% in the treatment cycle. Effect on GnRH analog on vaginal microflora, and you'll find intrauterine microbial colonization and occurrence of endometriosis in women with endometriosis. 73 women compared to 55 were control were studied. 20 of the women with endometriosis had 19 controls had received GnRH analog therapy for a period of 4 to 6 months in endometriosis. Significant shift towards intermediate vaginal microflora and a decrease in normal vaginal microflora in women with endometriosis was seen, and of course, respectively, P0.05 and 0.007. Bacterial vaginal examination of endometrial sample from all women revealed significantly higher colonization of Gardnerella and E. coli. That is why nowadays, post endometriosis, we are avoiding GnRH analog. We rather directly do IVF. We were suppressed for 3 to 6 months, but I think again results were very poor in those kind of patients. So intrauterine microbial colonization and the occurrence of endometriosis, this further emphasizes the importance of vaginal microbial profiling in the context of IVF embryo transfer treatment, as endometriosis is associated with infertility, and this study provides an evidence of the same. Although known pathogens such as Mycoplasma tuberculosis, chlamydia, Neisseria can cause infertility, subclinical changes in the microbiota in states like bacterial vaginosis are also thought to be the risk factors in subfertility. And we now know bacterial vaginosis is no more in vagina only, it occurs in all kinds of places. And we know the term bacterial vaginosis is deceptive since it's a disease of both lower and upper genital tracts. Chronic endometritis is characterized by presence of plasma cell in endometrial stroma. It's a subtle disease often overlooked by clinicians due to poor symptomatology, such as uterine bleeding, pelvic discomfort, and there are no symptoms at all. Implantation may be failure there, and 57% implantation failure may be seen with chronic endometritis. So when you put a hysteroscope, look at these micropolyps, and some will be better than even more than micropolyp. They are all evidence of chronic inflammation. I've seen big polyps like this as well, and it's very difficult to treat them. So additions in the intramural part of right fallopian tube and normal tubal osteoid seen there, once again suggestive of chronic inflammation. So the role of probiotics used adjunct to antibiotics, better cure, less circumference, less recurrence of bacterial vaginosis. We also can give vaginal probiotics or systemic. I don't think it matters much, though this article says vaginal is better. Systemic immunomodulation effect when given orally can be effective as well. So certain studies show improvement of clinical pregnancy rate in IVF cycle after probiotic use, management, manipulation, restoration of a robust vaginal microbiota has the potential to vastly improve women's health and disease prevention. However, a system level understanding of how the vaginal biota is associated with gynecological and reproductive health is still needed. A lot more work has to go on. And of course, they have to develop intervention which is effective. So, Voltaire, I quote and unquote, doctors are men or women who describe medicines of which they know very little, to cure diseases of which they know less, in human being of whom they know nothing. Sorry to say that. We have changed our lifestyle from apples to burgers, the temptation that transformed Adam and Eve's waistline. And that is the story of change in the microbiota and the gut microbiome. Cultivating health, the crucial microbiome connection to obstetrics and gynecology seems to be the future. An average span is gone up, but we know we're also increasing the size of our own abdomen and so on, which is not a good thing to happen. Hence, we now know all these microbiome, all these kind of fertility research is going on. The microbiome in health, to conclude, and the human diseases have its own impact on human reproduction, is becoming better characterized. New technologies and ways of thinking of the symbiotic relation between microbiome and the reproductive tract have a lot of accumulation data. And of course, however, no consensus has been reached to date on whether altered microbiome is cause or the effect of a disease. Thank you very much.
Thank you, Professor Pratap Kumar, for a fantastic talk. I think this was an eye-opener for many of us who are soul searching, trying to find the reasons why so many of our IVF cycles, in spite of very good embryos, in spite of very good endometrium, don't actually result in positive pregnancy tests. And that's something which is a chastening thought that despite having the greatest advances in medicine, sometimes it's because of the humble lactobacillus which is deficient in the genetic tract that ultimately our results are poor. Can I request Dr. Ramani Devi to give a few closing remarks and then introduce our next speaker, Dr. Epiphanam.
Thank you, Dr. Pratik. I think it was an excellent lecture, a real eye-opener for some of the reasons why, as you said, why the people, they don't conceive in spite of good embryos, good receptivity, everything. But and also why this rapid increase in the incidence of PCOS, endometriosis, and all the other things. So now we have an answer for that. Like whenever there is a change in the microbiome, we have to, sir has made it very clear that the microbiome is different from that of the microbiology of that particular thing. See, this microbiome keeps, like, it varies from the upper GI tract to the lower GI tract, and as well as in the vagina to the cervix and to the endometrium. So the most important thing for many of the diseases, be it a gynecologic disease like PCOD or an endometriosis or an autoimmune disorder or an ulcerative colitis and so many gut involvement, the basic reason is alteration in the microbiome. So for this, what we should do? See, we should go back to our olden days of manipulating the food as the first medicinal management of any disease. So once when the women, when the people have altered their food habits, automatically they have landed many of the disease process. And to share my experience on this uterine microbiome, we had taken few of around 60 to 70 of our patients where we did RNA PCR for the endometrium. And we have taken patients who had recurrent implantation failure or recurrent abortus. And we found out that there was a very low level of lactobacillus and these other organisms, some 18 organisms, like what are the common organisms we see, they were upregulated. So whenever these things, alterations are corrected, we are able to succeed in these IVF failures. Even up to 40% of our patients have conceived, and there is no, like, the incidence of recurrent abortion has come down. So I think in the current era of ART and reproductive health, microbiome plays a major role. And I should thank Dr. Professor Pratap Kumar for having given an excellent. Probably with this, reverting the possibility of reverting PCOS and endometriosis, all those things lies only in the alteration of the microbiome. I think nobody could have spoken about this other than Dr. Pratap Kumar in this excellent way. I should thank Pratik.
Thank you so much, ma'am. Backend team, can we have the CV of the next speaker, please? We would like to welcome Dr. Ritu Khanna, requesting Dr. Ramani to please do the honors.
So next, I'm very happy to welcome Dr. Ritu Khanna, who is the director of Khanna Medical Center, infertility specialist and an endoscopic surgeon. And she is currently the chairperson of Foxy Food and Drug Medical Legal Surgical Equipment Committee and secretary of Society of Fetal Medicine, and she holds various positions and executive member of UPCOG, and so many conferences she has conducted. And the most important thing is, I should say, she is a B.C. Roy Memorial Awardee in 2018 for outstanding contribution in the field of obstetric and gynecology, and as well as Presidential Award by the IMA Banaras for an exemplary good work done, and Best Chapter Award and Best Executive Award in 2016, and again Best Paper Award in UPCOG. And I think we could have seen so much of work that has been done by Dr. Ritu Khanna as a chairperson of the Food and Drug Committee of Foxy. I wish she should succeed more and more in all her future endeavors. And with this introduction, I request her to start the topic. Yeah.
Thank you so much, madam, for those very, very loving and kind words. And it's always an honor to have your wishes and blessings. And with that, I think we always will keep moving forward. And thank you so much to Dr. Pratik Tambe for inviting me to this launch premier CMEs of Infertility Management ART. And it's always a pleasure to be in this platform of this. So I think it's an era of individualization. And so is the case with the luteal phase. And we start with the individualization of the luteal phase support. We know that the luteal phase events are dependent on all the follicular recruitment and follicular genesis, and there's a shift of the FSH dominance to LH dominance in the luteal phase. And it's also crucial, we all know LH is required. But why is it so? It's for the because it's totally responsible for the steroidogenic activity of the corpus luteum. Not only this, it's going to upregulate the growth factors, VEGF-A and FGF2, and also upregulating the cytokines. And we know that these cytokines are important for the implantation. And also it stimulates the LH receptors in the endometrium. When we look at the luteal phase, progesterone secretion starts 30 minutes after the LH surge, and we know that the implantation occurs between day 8 to 10 after the LH surge. In the earlier luteal phase, the luteal phase is non-pulsatile. That means that the large granulosa luteal cells produce a large quantity of progesterone, but are not LH receptive, and therefore they only account for a basal progesterone secretion. Now, in the later phase, the small luteal cells become LH receptive in the second half of the luteal phase, and they are responsible for the hormone, HCG, and pulsatile changes in the circulating progesterone levels. Also, we know that we have a lot of evidences that progesterone is effective and is needed in the luteal phase. And some of them stand as, if you remove the corpus luteum prior to 7 weeks of gestation, it leads to a pregnancy loss, or mifepristone is used for pregnancy termination. So coming to the luteal phase, we know all of us, this is the natural luteal phase in the natural cycle. And we find that in ovulatory women, 92% of the cycles show a normal luteal phase, and luteal support is unnecessary, because the endogenous LH there is sufficiently high and it lasts for 48 hours to rescue the function of the corpus luteum. And the estrogen peak causes sufficient progesterone receptors, and therefore we do not need the supplementation of progesterone in our natural cycles. But in spite of all that, we still find that there is a luteal phase defect in about 8% of our cycles. Moving on to the support in the non-ART cycles. Now, when we're moving to the non-ART, we sometimes find that there is inadequate FSH and estradiol levels, which make the corpus luteum less responsive to the LH and FSH. But why does this happen? There may be an abnormal FSH-LH leading to faulty HCG-FSH receptors or an aberrant follicular genesis. And whenever the follicular genesis is defective, the corpus luteum dysfunctions, and therefore you get a less of progesterone secretion. Also, there could be conditions like an hyperprolactinemia, which will lead to an inadequate corpus luteum dysfunction, and that decreases progesterone because we know that hyperprolactinemia would also disturb the GnRH pulsatility and in turn disturbs the FSH and LH, or it may be an end receptor organ disturbance, which will lead to defect in the luteal phase. So what do we do in these? In these conditions, we first of all correct the underlying conditions, that's hypothalamic, hypothyroid, or hyperprolactinemia. And after we've corrected all these conditions, then we start correcting ovulating induction for these patients and give them progesterone. Moving to our IUI cycles, we know that sometimes we're using clomiphene citrate. The clomiphene citrate is able to stimulate ovulation by competing with the estrogen for binding with the hypothalamic estrogen receptors. Now, these estrogen receptors are blocked, and therefore we have an increase in the GnRH. So additionally, the clomiphene citrate increases the pituitary sensitivity to the GnRH in a similar fashion to estrogen. And as a result, what happens is you get an increase in the LH and the FSH secretion, and that's the increase in the LH frequency is that increases the progesterone, and therefore there is a lengthening of the luteal phase, and hence because of this action and the high LH, it does not require a luteal phase support. They went into the studies to find out, let's look at it. Is it that one follicle, or if the number of follicles increase, do you really need to give a luteal phase support? Second et al. Said, yes, if it's more than one, you may require a luteal phase support. But Eshrey said, no, there is no difference as the number of follicles and the luteal phase support. Using letrozole, we are routinely using nowadays. It inhibits the conversion of androgen to estrogen, but we know that this effect is short-lasting, and therefore, if the follicular genesis is good, in even the letrozole-stimulated cycles, we would not be improving the pregnancy rates by giving any luteal phase support. Now, when we're doing our IUI cycles, sometimes we also use gonadotrophins. Whenever we are giving gonadotrophins, there is a supraphysiological steroid due to gonadotrophins, and this decreases the LH by a negative feedback to the hypothalamic pituitary axis. Now, whenever this LH decreases, it's going to cause a luteal lysis, and therefore the progesterone is going to decrease. So the gonadotrophin cycles require luteal support for the higher pregnancy rates. There has been found that when you stimulate your patients with FSH, there is a shortening of the luteal phase in 20% of our stimulated cycles. And this is a recent meta-analysis, which was of 5 trials, which said that yes, if you support them with progesterone, they increase in the live pregnancy rates. So improvement seen in the FSH cycles and not in the clomiphene stimulated cycles. To time our cycles, sometimes we also use antagonists in our gonadotrophin stimulated cycles. We know that the antagonists act by competitive inhibition of the GnRH receptors, preventing the native GnRH from now exerting its stimulatory effect on the pituitary cells. And so what happens is there is a prolonged decline in the LH and the FSH, and that lasts for 10 to 100 hours. because it's a competitive nature of the action of this effect, and that's dose dependent and depends on the equilibrium between the endogenous GnRH and the antagonist. Therefore, we must remember that whenever we are using our antagonist in our gonadotrophin stimulated cycles, it decreases the LH due to a pituitary disruption for a short duration, though, but still your luteal phase support is required in these stimulated cycles. Moving on to our ART IVF cycles, we know that in these cycles we need multiple number of follicles, and multiple number of follicles of different size may ovulate at different times, expanding what is called as the fertilization window. Therefore, both estradiol and progesterone after multiple ovulation is expected definitely to go to a supraphysiological level. And therefore, now when it goes, you're using either a gonadotrophin agonist or an antagonist cycle, either of which it may be. But we find that there may be a normal oocyte maturation, but the luteal phase length is reduced. Also, they have been found that when you see the endometrial biopsy on the ovulation day of a natural cycle, there are no secretory changes. But when you look at a gonadotrophin agonist or gonadotrophin stimulated, the endometrial biopsy on the day of ovulation will show secretory changes. And also the ovarian hyperstimulation is associated with endometrial advancement in the early luteal phase and endometrial delay in the late mid-luteal phase. So a normal corpus luteum function is always dependent on a pulsatile LH release from the pituitary. So when there are low LH levels in these IVF cycles, it will cause luteal lysis and therefore a shortened luteal phase and leading to also an implantation failure. Now, there are different types of triggers that we are using. We use an HCG, we use an agonist trigger. Let's see what happens. Whenever we use HCG, we know that HCG binds to the same receptor as the LH, and HCG has been administered, we know, for inducing the final maturation. Now, the earlier luteal supraphysiological steroid level due to the progesterone estrogen will induce a negative feedback on the endogenous LH secretion by the pituitary, and therefore lower levels and a subsequent disruption of the luteal phase initiate the luteal phase support. Now let's compare a natural cycle with that of an HCG-triggered stimulated cycle. Significant differences exist. And why is it so? Is because of the long half-life of HCG as compared to the LH. HCG acts in conjunction with LH, and LH has got a far shorter circulating half-life, and that's 25 to 60 minutes. But when you look at HCG, it's 24 to 37 hours. And moreover, if you still detect HCG, it will be found in the serum and the urine from 7 to 11 days after the injection. Differing biochemically characteristics of these two hormones suggest that HCG will affect the implantation window 4 days post-LH surge in the mouses it's been seen. So therefore, and we know that the HCG is produced as early as the 8th day after the ovulation. So there is a period of 4 days, and it is in this overlapping period that a luteal phase by progesterone is mandatory after ovarian stimulation for IVF to sustain any early pregnancy. Now, the GnRH agonist trigger when you're giving, it's only possible in a GnRH antagonist cycle. So GnRH antagonist has got an affinity coefficient 2 to 50 times higher than that of the endogenous GnRH for the receptor of GnRH. Now, in a GnRH antagonist co-treated cycle, a bolus of antagonist is going to displace the antagonist GnRH from the receptor, and therefore we get a flare of the LH and FSH. And the importance of this is that it's going to inactivate the oocyte maturation. Yes, we have an oocyte maturation, but look what happens. Unlike the natural mid-cycle surge of gonadotrophin, the natural cycle surge has got 3 phases. The first is 14 hours, then 14 hours, and then 20 hours. But when you're given an agonist GnRH, look what happens to the luteal phase. There's a steep rise and a steep fall, and the duration of 24 to 36 hours only. So you got a oocyte maturation, but at the same time, your luteal phase is shortened, a possible direct luteolytic effect of an agonist. And data from in vitro suggests that GnRH is able to initiate the apoptosis cascade in the granulosa cells. The physiological advantage of a trigger by agonist concept is that there's a complete dissociation between the trigger and the early luteal phase, and therefore allows individualization for the luteal phase, a concept which is different from the HCG trigger, in which HCG, apart from inducing maturation, also covers an early luteal LH activity deficiency only in the earlier part. So how do we overcome the post-agonist trigger luteal phase? If it's a high-risk patient and you really want to do a fresh transfer, you need an intensive estrogen-progesterone support. But sometimes also in your high-risk patients, you can do freeze all for all. If it's a low-risk your luteal phase, rescue could be done on the basis of the LH activity. So there are 2 strategies. One is you're going to give an exogenous support by steroids, and that's progesterone and estrogen. And the second strategy stands, you're going to stimulate the endogenous steroid support by adding LH activity, either in a form of a small bolus after initial trigger or by adding daily LH recombinant injections. So, following the initial research, there was exploration of so much of optimal modified luteal phase after GnRH agonist trigger successfully resulted in a non-significant difference in reproductive outcomes between a GnRH trigger and an HCG, however, an almost elimination of OHSS. And the fact urged Copenhagen GnRH agonist triggering workshop to suggest a time for change in practice in the triggering policies in the ERT techniques. So, corpus luteum rescue could also be done by endogenous steroid production, and that's use of HCG as a surrogate for LH activity to promote the endogenous steroid production by the remnant corpora, referred to as the European approach. So over years, there was an effort to find out what is the minimal HCG dose that is needed to rescue this corpus lutea until the HCG production has started by the implanting embryo, and that covers the luteal LH activity deficiency, but there should be no increase of OHSS. So GnRH agonist trigger in the early luteal support with a low dose HCG, combining it with the standard luteal support, is something which is physiologically plausible that a refractory period may occur after the initial GnRH agonist trigger. And in that time, it's a time when the human granulosa cells will not respond to subsequent LH exogenous stimulation. So then came up the concept of fine-tuning to find the minimal dose and the tune when this HCG should be given so that you can secure an optimal pregnancy and also at the same time lower the risk of OHSS. So there came the concept of triggering by an agonist, and giving an HCG 1500 IU was the ideal dose that was suggested, and the time was after the oocyte retrieval. Along with it, the vaginal micronized progesterone and the estrogen oral supplementation was done, which resulted in a reduction in the OHSS, and you got much more mature oocytes. GnRH agonist trigger, and you could also have an exogenous steroid-free luteal phase. To avoid the inconvenience of giving a vaginal or an intramuscular progesterone, the progesterone levels were achieved by the strategy of exogenous LH activity administration, either by HCG or LH, and that could induce higher uterine progesterone levels and a more steady penetration to the endometrium than those achieved with an exogenous progesterone regimes. So this exogenous steroid-free luteal phase was that you're doing an antagonist, you're giving an agonist trigger, you're giving an 1500 IU of HCG on the day of oocyte retrieval, and then after 4 days, you give 1500 IUs of your HCG. Some could also use a recombinant LH, and the favor goes into the short half-life of recombinant LH, but yes, we are not using because of the high cost of the LH. GnRH agonist trigger and an exogenous support, that's a policy which was described as the American approach, and this is based on the luteal phase regime used for the oocyte recipients. While the recipients are being treated with the luteal phase intensive support using intramuscular progesterone and a transdermal oral estrogen after transfer of oocyte donation, and this concept disregards any corpus luteum function, and it relies solely on all the exogenous luteal phase you're giving after an agonist trigger. And once pregnancy achieved, you continue for 7 weeks or maybe up to 10 weeks of gestation till there is a luteal placental shift. Sometimes we give a GnRH trigger also, and there we combine a standard luteal phase support, and that's how we move forward with it. So a dual trigger we give for a final maturation with the agonist and also with an HCG. So we get a mature oocyte, and also you can do your luteal phase support in the initial supplemented by your progesterones in the further cycles. So now if you have modified luteal phase support, if you've done a fresh ET, yes, you want to do it in a GnRH agonist trigger, then this is a study by and recommendations by Himayuddin that if it's less than equal to 14, you give 1500 IUs HCG at OPU and 1000 in OPU plus 5 days and your standard luteal phase. If it's 15 to 25, you give a 1500 IU HCG at OPU and a standard luteal phase. And if it's 26 to 30 or more than 30, you do a freeze all for them. So the segmental policy was recently proposed, and of course, the GnRH triggered IVF cycles were having better and higher pregnancy rates when we did a freeze all and transferred in the further cycles. Yes, we have supplementation for elements of luteal phase, could be progesterone when they said HCG versus placebo, a higher pregnancy rate with HCG, progesterone versus placebo, a higher progesterone level, clinical pregnancy rate with progesterone. But we always recommend that, yes, we try to support with progesterone. But why is it so? It's because that when you give progesterone, there's an upregulation of these progesterone receptors, and therefore activated lymphocytes among the placental and the deciduous CD cells. And in the presence of this sufficient progesterone, these cells synthesize a 34 kilodaltons of protein, which is called as a PIBF, and that's a mediator which is going to substantially exert anti-abortive activity. Any routes of progesterone? Yes, they have benefits of their own, and it could be vaginal versus intramuscular or progesterone. They are all giving the same results. We are quite familiar with the doses that we are going to use in our IUI IVF cycles, and therefore we move to them. And yes, so we say IVF ET from the day of egg retrieval, estrogen donation after estrogen priming, frozen cycles as for oocyte donation, IUF for insemination, 12 to 24 hours from HCG on day following HCG. So therefore, you can stop after there is a luteoplacental shift, and sometimes in recurrent pregnancy losses, we extend for a longer time. So decisions are the hardest things to make, especially when it's a choice between what you make and what it is right. So critical thinking, problem thinking, and then getting a solution and making good decision is a crucial skill at every level. So thank you so much for the patient here.
Thank you very much, Dr. Ritu Khanna, for a wonderful talk. I think your talk was again another eye-opener oration because it told us that one size never fits all in ART. You need to always individualize your treatment to the particular patient, to the clinical situation, and ensure that your protocols are in line with modern thinking. You need to be able to give the best possible success rates consistently over time. And at the end of the day, we owe a duty to our patients to try and give them individualization as far as treatment protocols is concerned. Luteal phase support is something many of us take for granted, but you told us that it needs to be actually micromanaged from patient to patient, and different patients who are done on the same day may require different protocols for luteal phase support. I would invite Dr. Ramni Devi, our esteemed chairperson, to give us her conclusion comments.
I think this was, as you said, it was an eye-opener talk. she has given from basic what is the physiology and how it differs in natural cycle compared to clomiphene induced or letrozole induced, and what happens when you add gonadotrophins. So the luteal phase deficiency, or rather the luteal phase support, has been dealt clearly in all these varying protocols, and ultimately the individualization of the protocol, it depends upon the protocol that has been used and the individual patient's approach, and what is the type of the stimulation that has been ovulation trigger that has been given, and how long to support the luteal phase. All those things and the ways of this using progesterones and addition of GnRH agonists as well as addition of estrogens, all those things she has mentioned very clearly, and wonderful, Ritu, wonderful.
Thank you. Thank you so much, madam.
Thank you very much, Dr. Ramni, for your concluding remarks. We have a couple of questions which have come in from the viewers who have logged in. There's one question from Jamshedpur, and this person is asking, Madam, do you give HCG as you mentioned in your talk for all of your patients? Obviously, that is not the take-home message, but I would let Dr. Ritu elaborate.
Yeah, it's not for all our cycles. We individualize all our cycles. And of course, yes, if they are stimulated cycles, we like to time them. And therefore, if you're going for an IUI, we like to time them. And that's the cycles where we use our HCG.
Right. I think that's a very important take-home message, that you need to individualize. You don't give HCG to everybody. And remember that if you're doing a freeze-all, then all these questions are actually moot, because these sort of modifications that we make to the luteal phase protocol only apply if you are doing a fresh transfer. These are not for HRT, FET cycles. I wanted to ask Dr. Ritu, this is my own personal question actually, regarding the issue of HRT, FET versus natural cycle embryo transfer. What is your take on the whole situation? And how would you modify your luteal phase support in that case?
So the only thing is that we have to have a good compliance of the patient when we are going in for a natural ART, because sometimes we are going well, but he doesn't turn up in the last 2 days, and there we miss out this. So I still prefer to go in for a freeze and ART cycles, because there is where you can really time them. And you can even go ahead with all the luteal phase that we have discussed. So that is much better. But if you're very sure with the compliance of the patient, and the patient doesn't want any other injectables and all, and is quite tired about it, or sometimes with the poor responders, we just fed up, and then we go for a natural cycle. But yes, we counsel the patient to be with us or do an LH testing, because so that we don't miss the bus with it.
Again, that is a very steep learning curve, as personally I have also learned the hard way. We have to unlearn a lot of things, learn a new thing, and try and get enough cycles under our belt with these new protocols, which are now being used in Western countries. We have just started them in the past few months or years. And maybe we need to accumulate enough experience before we can fine tune those protocols as well. There's one question which is coming from Jaipur, and this person is asking, Madam, do you think that the use of GnRH agonist depot before doing your transfer helps? I know this is not related to the talk, but since the question has come in, can we take that?
Yeah, so he's asked, depot is used, and then you want to change the...
An HRT, FET cycle probably, whether we should, as a routine, give GnRH agonist depot before we start the estrogen.
It's not, I think we are using not in routine, but some of them are using, like in endometriosis and all, we start with those depot and then we do, or otherwise we can even do a short term regulation and go with our cycle. So it's not with all, it's a selection of the patients where you want to do a depot, use it and then proceed. And it's mostly with the endometriosis, or if your patient can't come for a follow-up, you tell your patient, yes, you take this and you come on the day of the stimulation when you're going to start.
And one final question. This actually is the question. Yes, ma'am, Dr. Ramini.
Yeah. See, I routinely use GnRH analogs, especially in adenomyosis and endometriosis patients, before FET. I just go ahead with stimulation, freeze-all. Then that is, again, I give 2 to 3 doses and I measure the endomyometrial thickness. If the junctional zone thickness is only around 8 to 9, maybe the transfer looks good. Otherwise, the chances of failure is quite high. So these are certain, and sometimes in repeated implantation failures, we can miss very early adenomyosis also. So there have been references where they say, give 1 or 2 shots of GnRH agonist, then you go for FAT cycle. That also gives fairly good results.
Yeah.
So one final question we were about to take, and this actually comes from Kochi. And I think this is a question which is asked very frequently by people who are in the initial stages of their ART careers. Which is the progesterone that you prefer? What dose do you give and how long do you give?
So the progesterone which is preferred, if you ask, my preference is for a vaginal progesterone, and that's because it's readily absorbed, and so that is. But for vaginal progesterone, of course, you need a lot of counseling for your patient, because otherwise they come up with those discharges and everything. But once you counsel them very well, they will never come up with things, and they're going to use it. And the second is about the dose. When you're giving it for IY cycles, we don't use, if you're stimulated cycles with gonadotropin, we don't give something more than 200. But if you're going into your IRT cycle, we use it from at least 400 twice a day. And so that is the dosage that we use. Intramuscular, yes, we try to avoid as much of injections that our patients can. So if they can take, there's no comparison to a vaginal progesterone.
So I think everybody has their own preferred route. Some people
Yes.
like to combine multiple routes in case compliance is an issue, as Madam just mentioned. And one size never fits all. You have to individualize it and again tailor make it to your patient depending on the clinical situation. That I think is the message for me. Thank you very much, Dr. Ritu Khanna ma'am, for being with us and enlightening us on this difficult topic, especially the newer recent advances which are now being implemented in Western countries. I'd like to thank both of our chairpersons, Dr. Mala Srivastava, who joined us briefly from the OT, and Dr. Ramani Devi, who's been here right since the beginning of the program. Thank you very much for being here, ma'am. And I wish you all the very best for your elections. Dr. Ramani is standing for the ICOC Vice Chair, and I wish her all the very best in her quest to attain that position.
All the best, Ramani Madam. And
Thank
you so much, Mala Madam, Ramani Madam, Pratik sir. Thank you so much.
Thank you.
Thank you. So I think after two fantastic talks by Professor Pratap Kumar and Dr. Ritu Khanna, we have the pleasant duty of moving ahead to the panel discussion, which is on optimizing ART results. Can I request the backend team to please share the CV so that we may introduce the panelists, please? I would request all the panelists to please switch on your videos and be ready. First and foremost, we have Dr. Deepa Maheshwari. She has the unique distinction of winning 22 gold medals in her undergraduate and postgraduate career, which is actually a very scary thought for a moderator like me, because then probably she knows much more than I do about the subject. I hope she can join us. Next, we have Dr. Anchal Garg. Can we have the next slide, please? She's from Lucknow and she heads Colors IVF Infertility Center, educated and trained at multiple centers abroad, including the UK and Germany. Welcome, ma'am. Next slide, please. We also have with us Dr. Shweta Kaur Jha. She is a dear friend since many years. She is now the secretary of the Indore OBGYN Society. Again, she is one of the leading lights as far as ART is concerned in the central zone of India. She has very great difficulty in attending online events. So we are very happy that we are actually able to grab a few minutes with her. Thank you for being with us. Next slide, please. Dr. Lipika Mohrana is from Cuttack and she is a gold medalist again. She's a member of the ISAR Youth Brigade and also she's worked extensively with the PCOS Society of India. I had the good fortune to meet her just a couple of weeks back when the annual conference of the PCOS Society was held. She's also a very active academician contributing on many fronts. Thank you for joining us, ma'am. Next slide, please. And finally, we have Dr. Anurika from Salem. She is somebody who has worked both at AIMS as well as PMC Vellore. She was a member of my endocrinology committee when I was the COFI chairperson for endocrinology. Now, currently, of course, she is an assistant professor at the Government Medical College in Salem, and she is an ART consultant as well. So we have a host of senior academicians and clinicians who are here with us. I'm just going to go ahead and share my screen so that we can get started with the panel. A very important question. Are the slides visible? You can all unmute yourself. I'm assuming that I'm visible and audible.
Yes, sir, you're visible.
A few important points to keep in mind when we do a Zoom panel discussion. Look at this from the point of view of a beginner infertility clinician. So you have to explain things as if you are talking to a 5-year-old. We'll talk about 2 or 3 common clinical case scenarios in the time that we have allocated to us. Brief and precise answers are always welcome, especially if they're evidence-based. And if we have time at the end, then I would love to do a rapid fire round. If you wish to contribute, please raise your hand and we will allow you to speak as well. Let's go to the first case without further ado. This is a couple who's been trying since 7 years, and HSG shows frequent tubes. TSH and prolactin is normal. AMH also incidentally is within normal limits, which is a rarity in today's world because in my clinical practice, I rarely see patients who come to me with a normal AMH. They've already undergone multiple cycles of planned relations and timed intercourse. Now, you as the treating clinician have managed to counsel them about the advantages of hysterolaparoscopy and why it needs to be done to rule out organic pelvic pathology, especially if they've been trying for so long. And at hysterolaparoscopy, you found that there are endometriotic deposits. These were fulgurated. Now, post-operatively, they've come back to you for follow-up, and you need to make a treatment plan for them because we need to shorten the time to pregnancy in this couple. They've already been suffering for 6-7 years. Can I request Anchal to start the discussion and tell us how she would plan the treatment protocol for this couple? Dr. Anchal, please go ahead.
Good afternoon, sir. Everyone, thank you so much, sir, for having me here. So in this patient, since there are endometriotic deposits along the uterosacral ligaments, therefore she falls in the deep endometriosis category. And but she has been, and also she has been married for 7 years and trying to conceive since 6 years. So ideally, I would like to go for IVF. But if the patient insists for around 1 to 2 cycles of IUI, then I will go ahead with IUI and IUI with the gonadotropin stimulation because her AMH is within normal limits. So, but ideally, I would like to go for IVF in this patient.
So can I start by asking Dr. Lipika, this is a patient of silent endometriosis. Presumably, this is just stage 1 or stage 2 endometriosis. Can you tell us, Lipika ma'am, what exactly are the reasons why endometriosis patients don't conceive naturally or spontaneously?
Sir, first of all, thank you for having me with you. So the only reason which is proven and which still stands strong for endometriosis patients being difficult to conceive for them is the tubal factor, wherein there could be direct tubal blocks due to endometriotic patches, or there could be a tubo-ovarian anatomy distortion, possibly that causes an issue, and it causes difficulty for the fimbria to catch hold of the eggs that's released in the POD fluid. So these are probable only proven causes which cause infertility or subfertility in a couple with endometriosis. The other things, as we have...
Yeah, please go ahead.
Yes, sir.
Carry
So
on,
the
carry
other
on.
things which probably could be possible would be the lower oocyte quality in these patients. But recently I went through a paper which is endometriosis in ART outcomes. Is it time to rethink? And this was a multi-centric trial in which they have proven that the oocyte quality is actually not of suboptimal quality in endometriosis, and the blastulation rates and live birth rates are not compromised much. So the only thing that's proven is probably the tubal factor, more so the sperm factor, the semen factor, where the sperm function is compromised because of the inflammatory conditions in endometriosis. And another one is the infrequent coital frequency because of the pain associated with endometriosis. That could be the possible reason. Otherwise, I think the tubal factor still stands strong.
Thank you. I think you nailed it because you mentioned multiple different issues. Just to reiterate and for the benefit of the audience, number 1, there is going to be tubo-ovarian anatomy which is distorted. Number 2, there will be a silent tubal factor because of the chronic inflammatory state. Number three, occasionally you can have poor oocyte quality. Obviously, if the patient has endometrioma, the question of poor oocyte yield, poor oocyte quality, all those issues are going to come in. But even at stage one, stage two endometriosis, it is known to impact the quality and the quantity of the oocytes which are generated in a patient with endometriosis. So these are all the multiple different issues. Dr. Anurekha, would you agree? And I'm happy that you joined us because endometriosis previously, when I was a student 30, 40 years back, it was mentioned that it occurs mainly in the coastal belt. It may be related to people eating rice or exposure to certain toxins which may be present in fish or in salt water. Is that your clinical experience?
Sir, rather it is more theoretical, like there may be an in modulated immunological mechanisms. I mean, the immunological mechanisms will be altered, like increased interleukin-1 secretion, and there will be more activated macrophages in the endometriotic fluid. It's more theoretical, but practically, we can see a lot number of grade 1, that is mild, minimal and mild endometriosis patients who are conceiving with a fertile period. Like we'll be advising them a natural timed intercourse and they'll be conceiving. So the thing is, when there is an endometrioma, probably all these immunological mechanisms will be playing a role. So in those cases, we don't wait for IUI or a natural cycle. And especially in this patient, if I am given an option, I would like to advise them to go for an IUI like 1 or 2 cycles, as Dr. Anchal was saying, and then to go for an IVF as early as possible, because she is
So
already
let us
married for
hear.
7
Thank
years.
you.
Yeah.
Thank you. Let us hear from Dr. Shweta. Shweta is one of the first FNB degree holders in Madhya Pradesh. So she has a wealth of clinical experience, plus she also has a fantastic amount of theory knowledge. Would you agree that you can offer 1 or 2 cycles of IUI to this couple, or would you like to straight proceed with IVF? What do the guidelines say, and what works actually in clinical practice?
So I'm I'm really sorry I missed the case. So this was
कोई नहीं,
a
ये
case.
एंडोमेट्रियोसिस है, बच्चे नहीं हो रहे, 6 साल हो गए, स्टेज 1 स्टेज 2 है, आपने फल्गुरेशन कर दिया है, अभी क्या करना है?
No, but I think so. The other doctor said that we can try a few IUIs, isn't it?
Exactly. So that
So
is
yeah.
what we want your
So
considered opinion on, whether
because
IUI can be tried in such a couple, or should we straight proceed for IVF and not waste
this
any time?
this patient had only some deposit at uterosacrals, right? And they were
Yes,
fulgurated.
correct.
Okay, so the site seems to upgrade her this thing endometriosis, but still I think so agree with her. If the semen counts are good and if the patient is young, she can have control over hyperstimulation and IUI before going for IVF.
All right. I think that's a very good approach to take. So all of our panelists agree that we need to shorten the time to pregnancy by intervening. So the old days, 25, 30 years ago, when after surgery we used to tell patients to try naturally, wait and watch, all those days are gone now. Most patients want intervention, and that is also the correct approach to take as far as the evidence says. Now, can anybody from the panel tell me something about what we call endometriosis fertility index?
So the endometriosis fertility index is a scoring system which
Yes.
takes into account the historical factors like the age and the previous pregnancy outcomes of the patient, as well as the surgical factors which we find on
Very good.
laparoscopy. And then all the scores are added and we see like what is the total fertility index for the patient.
All right. Very good. So now once you have the endometriosis fertility index score, is this a subjective score or is it an objective score?
Objective score.
Object.
It's an
Objective.
objective score. So it can be independently verified by anybody depending on the findings at hysteroscopy, depending on what is the clinical scenario. And that's the beauty of the endometriosis fertility index. It allows you to triage a patient, and it also allows you to prognosticate a patient. Dr. Shweta, would you agree?
Yes, yes, yes.
So can you tell us, how does it allow us to counsel the patient and tell her what are her chances of conceiving in X number of months from this day onward.
So actually, to be very frank, I don't remember that score. I'm telling you frankly. I know that depending on score, you can prognosticate. But to me, most of the patients, they come and they are for IVF. And looking at,
That's a
looking
very
at the
practical and pragmatic approach to take.
but I didn't study for this panel. So, this itna score hoga to ye kahenge, wo kahenge. Itna I can tell you when it is minimal or moderate, then from our clinical experience only we can tell when she can go and try for natural or where she has to stage up to IUI or IVF. If somebody has read that score, they can share their views. No issues. Maybe
Can I request Anurekha to tell us a
Yes,
little
sir.
bit about what are the pregnancy rates depending on the EFI scores?
Sir, I would like to score this patient. Actually, endometriotic fertility index is based on mainly three components. The age, history-wise, it's mainly three components: the age of the patient and years of infertility, and then whether there is any prior pregnancy events or not. And then on surgery, on table, you have to grade whether it is a minimal, mild, or moderate endometriosis. I roughly remember. I'm just trying to contribute to the panel. And this patient is 33 years. The score will be like if the patient is less than or equal to 35 years, then the score will be 2.
So
So
let us say
actually,
theoretically, if
yeah,
this couple has an EFI score of say 6,
yeah. So
do you
approximately
think you can try with
score will
IUI
be
in such
5
a
to 6.
couple?
Yeah, she can try for IUI or time
Good.
length course.
On the other
So,
hand, if her score is 2, would you
yeah,
waste time with IUI or would you go
no,
ahead straight away with IVF?
no. If the score is less, we'll go for IVF directly.
Perfect.
IVF.
So
That's
this is a
score is
very
more.
easy way of counseling couples and telling them that depending on your score, this is the chance that you will get pregnant within the next 6, 12, 18 or 24 months.
Yeah.
Let's close that discussion.
Hmm.
And Dr. Lipika has raised her hand. Please go ahead, ma'am.
Yeah. Sir, actually, to be very frank, I also haven't used this in clinical practice, but as far as the score is concerned, I think it's scored from 0 to 10 based on
Yes.
those 5 criteria. I think 2 is for each parameter, and it's scored from 0 to 10, wherein
Correct.
if she has a score between 5 to 10, they have probably scored it according to natural spontaneous conception and not
Yes.
for any ART procedure. It's not classified according to IUI
Yes.
or IVF.
Yeah.
But there is a probably 90%, more than 90% probability of conceiving spontaneously if she has a score of more than 5. So it's between 5 to 10. But if she has a score of less than 5 or 0 to 4, the chances of spontaneous conception comes down to less than 50%. That's what I have a rough idea about, sir.
Perfect. So let's close this discussion around EFI. We will revisit a little later. The practical message that I want to give the audience, finally, what our panel is going to debate, is whether if we do IUI, what kind of stimulation protocol do we use in IUI? A vast majority of OBGYNs who don't practice exclusively infertility treatment would often do something called as a clomiphene stimulation because it gives multifollicular development and they feel that if they have more than one follicle, chances of pregnancy are good. Dr. Anchal, would you
Yes.
be in favor of doing a clomiphene stimulation for such a patient when you are doing an IUI cycle?
So for such a patient, I would like to go for the gonadotropin stimulation, because with gonadotropin, there are better chances of implantation and better results in IUI. But otherwise, when other patients come for IUI, then I go for a combined protocol with letrozole and later on 4-5 days of gonadotropin.
Okay. So you can either do a pure gonadotropin stimulation or you would like to combine it with letrozole, because if you use letrozole alone, it will give you monofollicular development and consequently your IUI success rate would be lower. Dr.
Yes, sir.
Anurika, can you tell us when you use gonadotropin stimulation, besides getting multifollicular development, what are the advantages for the endometrium and for implantation?
So, Bill, when we use gonadotropin, when we start with a low dose step-up protocol, like a 75 international units of
No, we
gonadotropin.
are talking only about IUI. We are not talking about IVF right now.
Yeah. when we start with the low dose protocol, like 75 units of gonadotropin per day, you can monitor like within 4 days. You can call the patient and can you do ultrasound for follicular monitoring. And with a low dose, you always have an advantage that you can keep a check and you can avoid multiple follicle stimulation. And sorry, I couldn't understand your question. You want to
The
know what
question
is
is,
the
does administration of gonadotropins increase your oocyte quality, improve the endometrium, and enhance your implantation?
Yes, sir. Actually, it is proven that when you compare with a letrozole or a clomiphene with a gonadotropin cycle, there is always an increased clinical pregnancy rate, even in IUI, and it is irrespective of the type of gonadotropin, whether it is a recombinant or non-recombinant one. So I prefer to use a non-recombinant gonadotropin for this patient, even if going for IUI.
So I think we've covered a lot of ground in this first case. Just to summarize, that there are multiple reasons why fertility is impaired in patients with endometriosis. We know that timed intercourse is not something we would take recourse to in this particular clinical case. Probably, if you wanted to be cost effective immediately post surgery and you wanted to save a little bit of time and money, you could offer IUI. Otherwise, probably IVF would be the way to go. Can I just take 1 minute to stop share and reshare my presentation? Please excuse me for just 1 second. I'm going to quickly go over the evidence as it stands, and I'm resharing my screen now. Is it visible? Yeah, I think it's visible now. So this is our ISHRE guideline from 2022. There are also multiple other guidelines, including the American College. This is the EFI, which was published way back in 2010. Some of us have used it, some of us don't use it in clinical practice. But the easy way to prognosticate is that if you have a higher EFI score, the chance that the patient will spontaneously conceive within 12 to 18 months is much higher. Those who have lower scores probably should be offered CRT much earlier. Let's go to the second case. This is a 32-year-old lady. BMI is 34. She's trying to conceive again since 7 years. She's undergone several cycles of ovulation induction and gonadotropin IUI. Except for PCOS, there is no other major identifiable factor. For ease of discussion, now she wants to undergo IVF. Dr. Lipika, you are from the PCOS Society. Would you like to take a stab at it and tell us how you would plan her treatment cycle?
Yes, sir, for sure. So because she's 32 with a high BMI, and it's already 7 years she has been trying, so IVF would be the modality of choice because she has already tried advanced IUI with gonadotropins. So I would just like, because from my clinical experience, I would like to share, sir, like routine investigations which are done before IUI. I would still prefer focus on doing an LH level because in patients with PCOS who have very high LH, we prefer giving 2 to 3 days of antag, bringing down the LH and then starting stimulation so that the oocyte quality is improved compared to the high LH level. And my choice of protocol would be obviously an antag protocol. Gonadotropin of choice can be either recombinant FSH or it can be HMG. A lot of people believe that senior people, they'd say that because it's a hyper LH secretion in PCOS, so don't go for HMG injections. But there is no such proper guideline as to which gonadotropin should be taken. So we can use either recombinant FSH or HMG both. I would start because she has a BMI of 34. So I think I would preferably start with a recombinant FSH of 150 IU and a HMG injection of 75, 225 in total of gonadotropins for to start with. And I would rescan her after 5 days of gonadotropin injection. And obviously,
Let's hear from Dr. Shweta. In a case of PCOS, again, you are always worried that either she might be a poor responder or she may be a hyper responder. We know that PCO patients, by definition, every textbook shouts from the rooftop that they are hyper responders. But occasionally you may come across PCO patients who are poor responders as well. How do you identify whether the patient is a hyper or a hypo responder before starting the treatment? Dr. Shweta, can you tell us?
So before starting the cycle, uh, I really don't know.
Would you
But
be
will
able
be
to identify based on, say, an ultrasound scan, an antral follicle count, or an AMH level? Anybody else? Anshul, you want to take that?
Yes, so we can assess if the patient is going to hyper respond by if the patient is young and they are thin, and also if the number of follicles are more and more than 15 to 20 on the higher side of the PCO, and
Okay.
also if the ovarian stroma is less, and
Can I ask Dr. Lipika has raised her hand? Can I request you to please go ahead?
now
Sir,
how
there
to
are two.
identify the one who will poorly respond? That is
Hmm.
what I don't know.
So the thing
Yeah,
is
comment
that
it.
if Sir, probably the if you scan her on a baseline scan, and if we find that the stromal volume and echogenicity is more, the stroma is thick. So those patients are actually resistant to stimulation because that stromal volume suggests the androgen activity in those patients. So I find usually with stromal volume, excess of stroma or echogenic stroma, they are usually resistant to stimulation. That is one. And because this patient has had 3 cycles of IUI with gonadotropin, I would see her previous response to the dosage of gonadotropin and follicular growth in the IUI cycles, which have been done prior to starting IVF.
Very good. So, Dr. Anurekha,
Sir,
do
I
you
would
think that a particular AMH level can point us in the right direction when you are tailor making the gonadotropin dose for the patient?
Yeah, I would suggest to do a antral follicle count as Lipika said, and along with that, an EMH. If the AMH is more than 4, you can expect her to be a hyperresponder. And if it is going to be less than 2 or it is around 2 to 4, you can expect it to be either a normal responder or a poor responder. You cannot
Yeah.
predict in a
Occasionally, you can get patients who are AMH more than 6. So they
yeah,
can be either exquisite hyperresponders or
hyperresponder.
they can be poor responders who don't respond to a particular dose of gonadotropin. Which brings us very nicely to the concept of what is FSH threshold. Dr. Anchal, do you want to tell us what is FSH threshold for the benefit of the audience?
yes, so FSH threshold is the level beyond which the recruitment occurs, and that is different for every patient, depending upon the antral follicle count and the AMH of the patient.
So
And
would I be correct if I said that the FSH threshold for a PCO patient is lower as compared to a normal responder?
yes, sir.
Is that the reason also why we start very small doses in these patients because we are scared of hyperstimulating them?
Yes, sir. Yes.
Dr. Lipika has raised her hand again. Go ahead now.
Sir, actually, to be very frank, FSH threshold is something for PCO patients. It is absolutely undefined. There could be a cohort of follicles which is not responding to any dose of stimulation, and suddenly you find a group of cohort of follicles growing, like a burst. So that is why, because just because of looking at her BMI, I thought of starting 150 plus 75. Had she been a little bit lower BMI with less of stroma, I would have preferred starting with 150 IU, sir.
Okay, so FSH threshold is something which varies from patient to patient. It also varies in the same patient from cycle to cycle. And that is where it requires a lot of expertise, a number of cycles under your belt before you can fine tune your gonadotropin dosage for patients. Dr. Anurika, what is your preferred starting dose in a PCO patient? Is there a standard size which fits all, or you like to individualize it based on certain criteria?
There are usually individualized along according to the BMI of the patient and stromal echogenicity, antral follicle count, and AMH, like any age of the patient. Age of the patient. Like in this patient, I would also agree with that 225 or 200 to 250 of recombinant gonadotropin. And individualization is always better to start. I mean, for a starting dose, and also after you have started, you have to again retrospect, like after your first scan for follicular monitoring on the 4th day, again you have to retrospect. You can add
So
your
if I tell you that in her previous IUI cycle, we gave her 75 IU and she generated one follicle, what would be the correct starting dose for this patient?
So maybe we can start with 150 international units.
Okay, okay. And you can
And
build
then
on
again,
that later when you call her for a follow-up scan. right?
Again, and the fourth day of the scan, again you can see, like if you have more than 3 or 4 follicles reaching up to the 12 millimeter size, then you can continue with 150, or else you
This
can
brings
increase.
us to a very nice point in the discussion where Dr. Shweta is going to tell us what is her preferred choice of protocol. Is it the antagonist protocol or does she like low dose step up protocol, which is the safest protocol?
So we are talking about IVF, right?
हाँ,
Yeah.
IVF की बात चल रही है.
So
IVF का
why we
discussion
have
खत्म
to
हो
do
गया है.
the low dose step-up protocol? Straight away
Because
anti
we are afraid
protocol.
of making our patients land up in the ICU. That's why.
No, sir. With anti protocol, if you are starting in this patient with 225, and you're anyways going to give an agonist trigger and freeze her, I
Okay.
mean, it is a very less chance that this patient receiving agonist trigger will end up in ICU. I'm really
Okay.
sorry, but whatever in my experience, I've seen people landing in ICU are the ones who had HCG trigger and they had transfer also. I
Very
mean,
good.
when आप बिल्कुल ठान ही लो ना कि मतलब इसको पहुंचाना है तो ये चाहेंगे, अदरवाइज तो मतलब nowadays it's like quite मतलब in control.
So as far as preventing OHSS is concerned, there are multiple interventions that we can put in place before the cycle starts, during the cycle, and after the stimulation is over. So one of the things that we have discussed is to start with the lowest possible dose. Number two is to individualize the dose to the patient. Number three, frequent monitoring and make sure that you yourself are doing the scans. If you believe in E2 levels, then you follow up with the E2 levels personally. Don't outsource it to somebody else. Don't get the scans done by a radiologist or by your junior. You have to see the patient yourself because tomorrow if she explodes, then you will be responsible. Before we start the cycle, Dr. Anchal, do you think insulin sensitizers help to reduce the risk of OHSS?
Yes, sir. I have been giving metformin for such patients where either their blood sugar is on the higher side, or if, like in this patient, the patient is obese. So I would like to start her on metformin and along with the gonadotropins.
Okay. Dr. Lipika, in your experience, does metformin work well, or some of these new insulin sensitizers that are now available work better in your experience?
No, sir. I think it's an age-old drug and it works wonders in all fields. So I guess she's already on metformin before we start IVF. And I would prefer continuing on metformin because I've seen response being better because the
Okay.
insulin sensitivity comes up and the
Very good.
androgen resistance because of hyperandrogenemia also comes down. So I've seen very good response with the metformin on treatment while she's on IVF stimulation.
So in an ideal world, we would like to put the patient on an insulin sensitizer for at least 1 to 2 months before the index or the treatment cycle. Unfortunately,
Sir,
not many of us
to be
have
very
that
frank,
luxury.
when she's on for IVF and she's undergone 2-3 cycles of IUI with gonadotropin, I guess she already would have been on metformin for quite
Correct.
some
So this
time.
is what I'm trying to
And
say, that often patients come on the first or second day of the period, hold a gun to the doctors and then say, doctor, stimulate me now. I want to undergo an IVF cycle just now. So in an ideal world, we would like to pre-treat them with insulin sensitizers to optimize the cycle. We don't always have that luxury, but this is what we need to put into clinical practice. Dr. Shweta, can you tell us how do you monitor this patient? Do you use purely ultrasound or you use estradiol levels or use a combination of both? What works in your experience?
Sir, I do only ultrasounds, but on the day of trigger, I do estradiol and progesterone level also.
Very good.
Though all my cycles are going to be freeze all cycles, but still I do progesterone. I get to know sometimes progesterone is high, so already my embryologist will be telling that gande eggs milenge. So for that prediction and counseling and all I do.
So now we've
And
come to the point where you're going to talk about trigger criteria. Okay. So before we talk about trigger criteria, we need to talk about a very important concept, and that is when do you start your GnRH antagonist? Dr. Anureka, in an PCO cycle, would you start your antagonist on a particular day or again you individualize it?
It's not a fixed. I usually follow a flexible antagonist protocol. So when a leading dominant follicle of more than 12 millimeter is reached, I start the antagonist.
So why do you start at 12 millimeters? Why not at 14 millimeters, which is the classical teaching?
More than 12 millimeter.
Flexible.
If the leading follicle is more than 12 millimeter, I start antagonist. It is
Correct. So what is the rationale behind starting it at 12 and not at 14 millimeters, which is in inverted commas the dominant follicle?
So it is the rationale is nothing but like if you are going to start it later, I mean at 14 you may be at risk of having a premature luteinization,
Very good.
especially in a
Very good.
PCOS patient.
So in a PCO patient where 8, 10, 20, 30, 40 follicles are growing simultaneously, your estradiol threshold may be crossed and triggered even though the follicles have not reached 14 millimeters, and therefore you would like to start with it earlier. You don't go with a fixed approach, you go with a flexible approach. Very good. Now, what are your trigger criteria, Dr. Achan? The classical teaching is 3 follicles of 17 millimeters.
Yes,
Is
sir.
that okay?
Sir, 2 to 3 follicles of 17 to 18 and then I do the estradiol and the progesterone, and we give the trigger, and the agonist trigger we prefer for this patient, PCO patient, so that there are no chances of OHSs.
Okay. Dr. Lipika, if I can ask you, if you see 3 leading follicles, is that enough in a PCO patient? Or do you want to wait for some more?
So on which day, sir? On which day of stimulation?
When you are ready to give your trigger, you've reached 17 millimeters, there are 3 follicles, which is classical teaching. Is that enough in a PCO patient? Or you want to wait for one extra day and let some more follicles reach
I would
17
wait for one extra day, sir, because
And
in a
why
PCO.
is that?
So because in a PCO patient, 3 follicles were 17 before trigger, I don't think it's enough.
Yes.
Because expected response was much more.
Correct. So Dr. Anchal, if I can ask you, if we are seeing a cohort of say 10 follicles in both the ovaries, total of 20 follicles, and we are getting about 5 to 6 follicles which have reached 17 millimeters. How many
Yes.
M2s would you expect at the end of your oocyte maturity?
So from a cohort of 10 follicles, and sir, around 5 out of 7, sometimes, or
You
maybe even
wouldn't
6.
get the
And
total number that you expect. Dr. Lipika has raised the hand.
yes,
Please
sir.
go ahead.
And sir, it also depends on the days of stimulation, sir. Even if we have
Yes.
given her 9 to 10 days of stimulation, and after that the follicle size is 17 or 18, then I would like to go for the trigger.
Okay. Dr.
So I
Lipika, you
think,
had something to add? Yeah.
yes, sir, I think 10 follicles on each side. So 20 antral follicles on the start of stimulation. So I would expect around 10 to 12 M2 oocytes. A minimum of 10 to 12 M2 oocytes at retrieval.
Okay. So the short answer is what we expect, we don't always get in that. We may expect that 8 to 10 follicles have reached 16, 17 millimeters, but in clinical practice, we may get far fewer than that. It not only depends on the duration of stimulation, the dose of gonadotropins, and the choice of gonadotropin, but also in PCO, as we know, reproduction is not an exact science. So what you see, you may not always get. What you retrieve may not always be an M2. And out of all the M2s, you may not always get grade A blastocyst after 5 days. So this is something which we need to keep in mind. That's why you may need to wait for 12 extras or 24 extras before you give that trigger. You may be worried about OHSS, but at the same time, you have to balance the number of metaphase 2 oocytes that you're going to. If you get about 7 or 8, that will give you at least 2 good blastocysts, which are enough for 2 embryo transfers. So can I ask Anurekha now, do you always freeze all in a PCO patient? Or would you like to do a fresh transfer sometimes?
Yes, I prefer to freeze also for all
Freeze
the
all for
all the PCOS patients.
Freeze all for all PCOS all the time.
Yeah, and one more thing regarding trigger for this patient, I would like to have a dual trigger because she's already 33 years old, and I expect her to be having a delayed response, and maybe she would have got around
So for
10
the
to 12
benefit
days.
of the audience, would you like to tell them what is dual trigger?
Yeah, I would give an agonist, I mean GnRH agonist, as well
Which
as
agonist would you use
SCG.
in clinical practice?
So I usually give a decapeptyl 0.5 mg, and along with that, on the same day, I used to give a Ovitrel recombinant HCG up to 50 microgram. So
Aren't you worried that giving Ovitrel will push the patient into OHSS?
yeah, that is why I used to prefer freeze-all for especially in PCOS patient, because I think like because of her age and BMI, I may be getting a lesser number of N2 oocytes, and maybe the quality of oocyte and embryo, it's all a concern. So I prefer freeze-all after a dual trigger.
So Dr. Shweta, what is your preferred trigger? What do you use in your center?
So I use agonist trigger only.
So which is the agonist that you prefer? There are many agonists available.
Triptorelin.
Triptorelin, how much? 0.2?
Decapeptyl. 0.2.
Okay. Okay. Dr. Anchal?
Yes, sir. So triptorelin decapeptyl 0.2.
Okay. Dr. Lipika, any difference of opinion?
No, sir. I think triptorelin 0.1, 2 vials subcutaneously.
Okay. So I'm the only odd person out. I like to give Leuprolide 2 milligrams, and it works just as well as triptorelin, decapeptyl, etc. There's no difference at all, and it's probably easier to source also. Can we have a little bit of a discussion on freeze all? How do you counsel your patient? When do you counsel, and how do you counsel your patient for freeze all? Because if I look at it from the patient's point of view, they have been told that stimulation होगा, transfer होगा, 15 दिन के बाद blood test होगा, positive या negative symptom. So how do you counsel your patient in that case? Dr. Anchal?
Sir, I will counsel the patient and tell her that it is safe for her, and we want a safe, a healthy mother and a healthy baby, and we can't go for pregnancy at the cost of her life. So I'll explain that to her, and along with that, I'll tell her that once her ovaries return to the normal size, then we will be able to transfer the embryos so that everything can happen in a safe way, because we aim for an OHSS free clinic.
Very good. Fantastic. Now, Dr. Anurekha, this is the million-dollar question. When do you do this counseling? Do you do it on the day of oocyte retrieval when the patient is half asleep under anesthesia?
So we do have 3 counseling steps. One is before the procedure itself. So
Very
at that
good.
time, I explain the cause, success rates, and then the need for any additional, like the male having a TISA, or the female maybe having a chance of hospitalization after the pickup, because usually we do a daycare. So we may expect we may explain them the additional cost which may be incurred to that patient, and then again before starting the procedure, we again counsel them. They've come in the day 2 or day 3 of the cycle. We counsel them, and then we tell them the chances of freeze-all. And
so I think this is an important
also,
point that is touched upon, that there are financial implications for the couple as well, which they need to be mentally and of course financially prepared for. It's not something which is a surprise which we should spring on them on the day of new cycle retrieval. There has to be adequate time given. Ideally, when you're starting the cycle, you spend 10-15 minutes with them, explain to them that she's a hyperresponder, likelihood of OHSS is there. Therefore, the strategy is to freeze everything and then do a segmentation strategy and a stage. Yes, Dr. Shweta?
So nowadays, I think so, thanks to many friends, people are going for freeze-all cycle for all. So it is so easy to counsel them.
That's a very good. We could have a 45-minute discussion on that.
I am just telling you, patients are coming mentally prepared. They are surprised when I say that we can transfer also. First thing. Second thing, we are living in a place where we get the financial contract done before starting the IVF.
Excellent.
So these
Very
two
good
things.
point.
Yes.
Very
so
good
they
point.
have in written with them the form, and I tell them A to Z everything before starting the stimulation.
Awesome. So we are out of time for this case, unfortunately. So I'll quickly go over the evidence as it stands. This is the chronic low-dose step-up protocol. Sometimes when patients have had a previous admission for hyperstimulation, they are very thinly. You are afraid that they may be exquisite hyperresponders. This is the protocol of choice. Usually, unfortunately, results only in monofollicular development, so not very suitable for IVF, but the chance of OHSS is exactly zero. GnRH antagonist protocol is the one which 99% of us use in clinical practice. Again, remember, you have to individualize, start early because the FSH threshold may be crossed and the LH may be triggered. We also know that the old papers which first came out and described the freeze all gave us a cutoff of, going to skip ahead. Yeah, gave us a cutoff of 4,000 picograms of estradiol and 25 oocytes retrieved. But of course, in clinical practice now, we are not so lenient. We go for 15 oocytes or 15 follicles and a picogram level, estradiol level of 1,500 to 2,000 picograms. We know that the counseling is always much better received when the couple is counseled at the beginning of the cycle, especially regarding financial implications. And also, we need to be aware that the number of oocytes and the number of follicles may be more. That doesn't necessarily mean that all of them will be of good quality and will result in a pregnancy. This is the OHSS free clinic, which was espoused by Professor Deloy and the Belgians, who had the good fortune to visit a long time ago. And we already have discussed all of this in great detail. I'm going to skip past these particular cases because we don't have time to cover these. Maybe we will do these on another day. I want to go straight ahead to the rapid fire. So I hope all of you are ready. This is the last 3 minutes of our panel discussion. So I want a simple yes or no answer. I will take your name and only that person will respond. Okay. Lipika, mock transfer for all patients?
No, sir.
Okay. Anureka, yes or no? Mock transfer for everybody?
Anureka, you're muted. You're
Anureka,
muted, Anureka.
Only yes, no. Don't give us history, geography.
Anureka, madam, you're muted.
No
Unmute.
worries. Let's go to the next question. Anchal, day
Yes.
2 transfer,
Sorry.
day 3 transfer, or day 5 transfer? What would you prefer?
So day 5 transfer for everyone if we can, but for poor
So that's a
responders.
very important caveat. Thank you very much for telling us that not every embryo may reach day 5. Many people have
Yes.
that misconception in their mind. कि सब embryo blastocyst aren't there.
So in
Dr.
poor
Shweta?
responders with day 2, sir, good
This is
response.
rapid fire, so no discussion. Only yes, no. Okay. Dr. Shweta,
Mock-
can you tell us how do you select the best embryo?
Sir, mock ET, yes. Second thing is day 3, day 5. If we have a lot of embryos, then I prefer first transfer day 3. Okay.
Okay.
And
But the
then
question you have been asked, you have not answered on.
freeze the rest for day 5. I am not that person who
Which
will say take
embryo do you
everybody to
select
day
and
5.
how do you select? That is the question. You have answered other people's question.
So day 3, depending on their, size of the blastomeres, 8
How
cell,
do you
that's what
select
you
the
do.
best embryo?
On the
Do
day
you
3, na?
do you go by morphological criteria, visibility under microscope, or do you use an embryoscope? Do you
No,
use time
sir.
lapse?
Visibility under microscope.
Bah,
Time lapse is all
basics.
that.
Absolute basics. Very good.
basic.
That is the question that I want. Lipika,
Time lapse and
preload
all
or
is-
afterload?
Sir, morphology. Preload or
Lipika,
afterload?
preload or afterload?
Preload, sir.
Preload? Always
Yes.
preload?
Yes, sir.
Anureka, preload or afterload?
Always
Individualized.
afternoon.
If there
Sorry?
is if there is a difficulty expected, difficult transfer expected, I go for a preload. Otherwise,
Anchal, preload or afterload?
Afterload, sir.
Always
Afternoon.
afterload?
Yes, sir. Always afterload.
Always.
Sir.
Okay,
Always.
Anchal does what I do.
want the
I
embryos
always
to
do
be safe.
afterload. We will not
I-
debate the pros and cons because we don't have time for that. Shweta, ultrasound guided ET for everybody?
yes.
Always. I have not done without one.
Okay. Anchal, bed rest or no bed rest?
So just 10 to 15 minutes of bed rest. After that, patient
And
is
15
ambulatory.
days afterwards?
No.
No bed rest, sir. After
Okay.
15 days.
This is the last set of questions. Okay. So we'll start with Lipika. Progesterone for luteal support. Which dose, which duration, and which route?
So multiple routes I use. Injectable, 100 milligram progesterone injection, IM. That's one.
Okay.
Then 200 TID or 400 BD for vaginal. And I also give 8% 90 ml gel vaginal.
So you like to use at least 2 routes, right?
Yes, sir. At least 2
To
routes
cover
and
your
duration
basis.
will be at least till the established
Very
heartbeat. Still till
Anureka?
empty cell is done.
Anureka, any use of luteal estrogen
No, I
during the
don't do.
luteal phase support? No.
I don't do.
Okay. Anchal, any role of HCG in the luteal phase?
Sir, in fresh transfer, sir, we can give HCG, but
Do you
otherwise,
use it? Do you not use it?
In rarely in some cases we are doing fresh transfer. So when we are doing fresh transfer, then after about once the beta HCG report is there, then we may start it on HCG if the patient has.
Okay, let's pass this question. That's a very good discussion for another day. Shweta, GnRH agonist in the luteal phase, any role?
No, sir. I have not used. There was few papers, but I don't use.
Okay. Anurekha, last question to you. Do you use steroids in the peri-implantation phase? If yes,
No,
then
sir.
what dose and for how long?
No, I don't use.
Nobody?
I don't.
Okay,
I
fantastic. So
use,
thank you everybody for a
so I
wonderful
use
panel
steroids.
discussion. Thank you very much for sharing all of your knowledge with us. It's amazing to have all of you here contributing actively to this wonderful CME. I see Professor Pratap Kumar has joined us. Can I request, sir, to please share a couple of words with us? We missed you during the Q&A, sir.
Okay. No, I sent my recorded. I hope it came out well. So.
It came out perfect. It was fantastic. Highly appreciated by the audience. There were one or two questions, but I think going to paucity of time, we won't be able to take
That's
them.
okay.
Thank you very much for
Yeah.
sending them.
All the best. I just came to say I'm with you. So
Thank you very much, sir. Really appreciate it. So, to conclude today's entire program, I'd just like to place on record my gratitude to conference and the team. Can I request Makrand and Manish to please take a bow? Conference was established 8 years back in 2016. We have, through this particular platform, reached out to many nooks and crannies of the world, which we would not obviously have been able to reach physically. More than 90,000 doctors from 140 countries have signed up on conference. 44,000 gynecologists, which is probably the entire strength of Foxy today, are part of this network. 25,000 doctors regularly log in every month. And this is actually a fresh new step in a new direction for conference. We've hosted 7,000 plus CME videos on women's health on this platform. And the conference premium is yet another step. It's yet another feather in the caps of Makarand and Manish, the co-founders of conference. Can we hear from you, please?
Thank you, Pratik, for the wonderful words what you have said. But since 2016, this was much before pre-COVID era, where we wanted the academics to reach out to the nook and corner of India and also across the world. And only with the help of the digital medium, it could have been possible. And me and Manish have been striving for these things for so many years. And I think the academics is going to various places with the help of conference platform. Manish?
Yeah, thank you, Pratik, for inviting us onto our own platform. It's a great feeling to launch premium CMEs, and we hope it adds a lot of value to our viewers who've been repeatedly watching CMEs on conference since so many years. And Pratik, we are very thankful to you. You've been a part of many of our launches and a huge support to us. Lastly, I would like to thank the esteemed faculty members. It's only with your support that we can continue serving great online CMEs for our viewers, and I wish you all the best. Thank you very much.
Thank you, Pratap Kumar, sir.
thank you.
And the backend team for a fantastic event. At the end of today's program, I'd just like to take 1 minute to propose the formal vote of thanks. I'd like to express my gratitude to our esteemed speakers, Professor Pratap Kumar and Dr. Ritu Khanna, who deliberated on two very topical issues in the field of ART, especially those which have a great impact in affecting clinical pregnancy rates and live birth rates. Thanks also to our chairpersons, Dr. Mala Srivastava and Dr. Rani Devi, for doing the honors and sharing these sessions. We had a fantastic panel on optimizing ART results with so many different take-home messages, the active participation from our panelists, Dr. Anchal Garg, Dr. Shweta Kaul Jha, Dr. Lipika Moran, and Dr. Amerika. Thank you very much, all of you in the audience, for logging in, tuning, and we hope to see you regularly on the conference premium CME's platform. I'm really delighted to be doing the launch CME on infertility and ART under this new banner, and I look forward to many more exciting sessions in future. Thank you again for joining us. Until next time, goodbye.